I was asked to talk about evidence-based interventions for child physical abuse, which is kind of a fairly specific topic. And I'm going to broaden it to include a little bit on family conflict. And I realized that this is 1 hour in which to kind of give an overview of the area and summarize the treatment literature, the research literature. So it's mostly a presentation on the research literature. It's not really a presentation on how to do this work. I'll give some samples of what some of that work involves, but it really isn't a how-to type of workshop. For that, obviously, we would need far more time and a very different kind of format. So anyway, what I thought I would do, and you have copies of this, I believe, in front of you, which is good, is to say a little bit first about what do we mean by child physical abuse. And unlike some of the other presentations in this series, child abuse is not a formal diagnosis. It's not a disorder. You don't have child abuse, like you might anxiety disorder or a cold. And by the way, I'm sorry, I have a cold and a cough, and if I cough too much, let me apologize in advance. It's based on a set of experiences. So things happen to children, and there is a judgment made about those experiences that indicate whether or not that experience meets the definition of child abuse. And the definition varies. There isn't a set of behaviors that make up child abuse. Instead, we have to use our definition and look at what happened. And so there could be a broad range of behaviors. They vary in their frequency, they vary in their severity, they vary in their stability over time. So one act of aggression or violence might constitute an abusive experience, whereas in another case it might be several individual acts, a process of being, let's say, physically mistreated over a period of time that might lead to the decision that child abuse has taken place. So there isn't a constellation or a set of actual descriptions that make child abuse clear. Instead, it's based on a judgment, and those judgments are informed by very different policies, very different definitions. So the same behavior may not even be child abuse in one setting, whereas it may be child abuse in another setting. And the other comment I just want to make is that the definitions vary by various locations. So in Pennsylvania, where I live, our definition of child physical abuse is very different than the definition in Florida. And the definition in Florida is very different than the definition in Texas. So child abuse means very different things. It still may be something similar across states, but it may be very different things across the states. So I gave you two definitions that I just thought would be good examples. The National Incidence Study, there were three. So the NIS 3 study had this definition of child physical abuse. I'm just going to read it. It was present when a child less than 18 years of age has experienced an injury or a risk of an injury as a result of having been hit with a hand or another object, or having been kicked, shaken, thrown, burned, stabbed, or choked by a parent or a parent surrogate. I'm not trying to say that is the only definition one should use, or it's the best definition. It's just one that was used in a research study. And you can appreciate how very, very specific and very, very focused this one is. There are other data, not based on a research definition, other data that come from the states, the various states in the US. And they all have different definitions, and instead of defining it one way, there are studies that indicate how many different states report cases that they believe represent cases of child physical abuse. And so they report information about the number of victims who have received various physical acts that may have caused or could have caused a physical injury. So in some cases, a state may decide that an incident was considered child abuse even if it did not result in an actual physical injury. It could have. So you can appreciate how in some cases you might have actual instances in which someone's been hurt, they've been injured, being considered child abuse, and in other cases, a child may be considered abused even if there wasn't an injury. And for those of us who work in this area, this means there's a lot of variability in the types of cases we're going to treat. And I wanted to add one comment about the use of physical force. Everybody has a different opinion about force. It's a very personal thing, a very professional issue, and many people have very strong opinions one way or the other. I'm not here to argue a particular position as much as to say, I think we'll talk a little bit about today the role of physical force or corporal punishment or physical punishment. And that's because there are many studies that might not actually take cases who've been physically abused per se. They take cases of children who may have been hurt or who may have been exposed to harsh physical treatment, like a case of a child being asked to kneel on rice for an hour. Now, maybe that child wasn't injured, but that child was in pain, that child was humiliated. In some cases, physical discipline is a source of concern, and as a result, we'll talk about how to deal with what I'll call the continuum of force. The continuum of force means you might have actual physical abuse at the extreme, but you have a lot of cases that involve physical discipline, physical mistreatment, the punitive treatment of children in a physical way, which still may require some type of intervention. So I wanted to say something about the characteristics of children who have been physically abused. And some of you may work with or evaluate or advocate for children who've been physically abused. And this is based on the research literature. So you can see in this first column some of the characteristics that have been associated with children who've been physically abused. I added to this list characteristics of kids who haven't necessarily been physically abused. They've been physically aggressive to other people in order to show you some of the similarities and differences. But if you just look at the first column, what are the characteristics that our research literature suggests are associated with physically abused children? Well, probably the main or the most common characteristic is that those children themselves are engaging in aggressive behavior, or they have a fair number of behavioral problems. But the second most common is that they have poor social skills. They're very limited in their interpersonal skills. They're not very good at engaging in polite behavior, for example. A third characteristic is that they have negative attributions. By that I mean they may have views of the world that see others as blameworthy for their problems, or they may see themselves as blameworthy for others' problems. Like, if I hadn't called my dad a bum, he never would have hurt me. I should never have done that. Some children develop these misattributions where they see themselves as to blame for the problems caused in their family. Another is a fair amount of anger or anxiety. Sometimes children who've been physically abused have post-traumatic stress disorder. So you have these trauma-related emotional symptoms, and what's important to realize is it's not just anxiety, it also could be excessive anger or explosiveness. Limited peer relationships or family relationships, so these are children also who don't seem to be able to trust well, to have friendships. They don't have lasting friendships. They often don't have a close friend. Almost everybody in this room has a close friend, if not many. And these are children who, for many reasons, have difficulty forming these kinds of bonds. And then there are some signs from the neuroscience literature that indicate that some physically abused children have difficulties either with regulating their stress reactions, or they actually have changes in the brain, smaller hippocampal volumes, for example. So there's, again, information around the role of neuroscience and its relationship to child physical abuse. What I want you to see on this slide also is that children who are aggressive have many of the same characteristics. So this is why I keep thinking there's common ground here, meaning that aggression, whether it's directed to a child or whether that child is directing aggression to someone else, when there is aggression in the air, if you will, when there's aggression in a child, it looks as if they have a lot of the same characteristics. And it stands to reason, if a child who's been physically abused is very likely to be aggressive, you can see how that might transmit from the experience of abuse to now, abusing others or mistreating others. And so there's a lot of similarity between these cases. I wanted to say something also about the parents and the families. And I use the word parent, but I really mean caregiver. Sometimes they're not a biological parent. They're grandparents, foster parents, neighbors, other relatives. And what I wanted you to see as well is, when you look at the caregivers who have been identified as having been abusive, what do you see? What are the characteristics? Well, one is that they're aggressive, or they use coercive parenting, meaning highly punitive, sometimes very control and power-based parenting skills. They also have very limited positive parenting, all the nice things that parents say to their children, okay, attending to them and reinforcing them and praising them. These parents also don't engage in a lot of positive behavior. Some of the parents also have their own misattributions. They may see their children in negative ways. They may see their 2-year-old child as having spilled his or her milk because he's trying to make me late for work, as opposed to that's what 2-year-olds do. So we try to look for some of those misattributions or those highly critical attributions about their children. And then some parents have actual, emotional reactions themselves. They may be sad, depressed, they may be angry, or they may have post-traumatic stress disorder. And then in the families, you see the presence of coercion and conflict. So this isn't one parent or just one child. This means if you look at the interactions of the family, what you see is that there's a lot of disagreement, a lot of arguing, a lot of foment, okay, tension. And you also see that they don't solve problems very effectively. Their ability to solve problems in non-aggressive ways is fairly limited. And some of these families have very limited resources. They may not have much money. They may not have support from family members. They may not have support from their community. They may not have a lot of resources in the community, and many of them are involved in many different systems, such as child welfare and perhaps as well juvenile justice. And again, what you see in this right-hand column is that parents of children who are aggressive have many of the same characteristics. So there's a lot of similarity in the characteristics of people who either aggress towards others or are the victims or targets of aggression. And I think this is why I think of this as common ground. We have to be very concerned about the impact of abuse on children because they may be more likely to do the same thing as they age. And I wanted to put physical abuse in somewhat of a perspective. Some of you may know a fair amount about sexual abuse. Some of you may also have experiences around physical abuse. Since we're talking about physical abuse today, what I wanted to highlight are some of the differences between sexual abuse cases and what we get when we have physical abuse cases. And what I want to highlight is something which is fairly obvious, which is you are allowed in this country to use physical force against your children. In most states. I think it's probably every state. And it's permissible as a result. It isn't permissible to have sex with children. It is unacceptable as a societal norm. And this is one of the main differences that we inherit when we see cases of physical abuse. Parents have the right in this country to use physical force. So as a result, when you're entertaining a case and thinking about how to help a parent find alternatives, it isn't so easy at times because, on the one hand, the law does allow them to use physical discipline or physical force. But in addition to that, we find with physical abuse cases, as I just mentioned, there is a lot of aggression in the family. It isn't just a limited, for the most part, physical act against a child. There's usually a lot of hostility, there's a lot of yelling, there's a lot of cursing, putting people down, verbal abuse. All these things occur sometimes in the home. And so that's a context that makes treatment very difficult, and it has to be targeted in treatment. Whereas in sexual abuse, that context is usually not that present. There really isn't as much of this hostility, aggression in the families of sexual abuse. If anything, we have more support from usually a non-offending caregiver. And if anything, the likelihood of a child in sexual abuse cases being hurt by that family is low, but it's high in physical abuse. So as a clinician, one has to think really carefully about dealing with this context And this means that sometimes these children can be seriously injured. It means that safety is a real important concern for a clinician. And it also means that sometimes these are cases of life and death, even though that's more rare. So what are some of the challenging behaviors that you see in treatment? And again, these are just a couple. One being disinterest, a parent who says, listen, I don't really want to change my behavior, I didn't do anything wrong. A parent who says, you know, I've been doing something very reasonable, I was even told that I could do this by my clinician or my therapist or someone else. They dismiss the importance of changing their behavior. They feel very comfortable, they say, I'm doing fine, why do I need to change? They often aren't that excited about learning new things. They may be outright angry and hostile, you know, and threatening, like pointing fingers and raising fists. I mean, parents do raise their voices, get loud sometimes, and occasionally they might get actually aggressive, throw things, push things, whatever. Now, those are more rare, but these are some of the challenges that come with a family, a case that may be engaged in aggressive behavior on a regular basis, and it may have a lot of conflict. And so as a result, intervention has to address these. So I want to transition for a moment and say a little bit about what I'll call family-focused interventions for child physical abuse. And I would say these interventions have 4 common characteristics, and these are broad. First, they try to focus on dealing with safety, keeping a child safe, and stopping the abuse, stopping the harsh physical discipline if it isn't abusive. The second is that they work with both the child and a caregiver, oftentimes, for some of the time, together. So they're actually being put together in some or all of the intervention. The third is that they teach specific skills, very specific skills, to reduce distress and promote positive or adaptive behavior, meaning desirable behavior. And I'll say a little bit about what this means in a sec. And then the fourth characteristic is that they have a science base, they have evidence to suggest that they have improved the outcomes of children who have been physically abused. So they've specifically looked carefully in comparison studies where they have treated and followed physically abused kids and their parents, and they have evaluated outcomes to determine that their intervention actually improves the outcome for those cases relative to something else. Now, I'm not trying to say there are that many characteristics. These are just a few of the characteristics that led me to pick some of the interventions I want to talk about briefly now. And I want to just give you a flavor for each of them. And there are 4. One is called Parent-Child Interaction Therapy, PCIT, and PCIT has been around for a long time, developed by Sheila Iberg, actually at the University of Florida. But the version that's now being used with child physical abuse has been developed very nicely by Mark Chaffin and Anthony Urquiza. There's a second intervention called Alternatives for Families, a Cognitive Behavioral Therapy, AF-CBT, which our group has developed along with Alyssa Brown and her group at St. John's. There is a third intervention called Combined Parent-Child Cognitive Behavioral Therapy, CPC-CBT, developed by Melissa Runyon at the University of Medicine and Dentistry of New Jersey. And the fourth is called Multisystemic Therapy for Child Abuse and Neglect. And again, multisystemic therapy, or MST, has been around for a long time, used with a lot of cases of very difficult adolescents engaging in antisocial behavior. But this particular version for child abuse and neglect was developed by Cynthia Swenson. So I want to say a little bit about each of these treatments and a little bit about their research. So PCIT. PCIT is the most specific, and it is also one based primarily on behavioral principles. And its focus is on preschool and school-age children. But it was really mostly developed with the preschool child in mind. And there's 2 stages. They unfold over a period of about 12 to 20 sessions. The first phase is called the child-directed interaction. And what it does is it aims to restructure the relationship between the child and the parent so that the child has a stronger attachment to the caregiver. And what this means is that they're trying to get more positivity in the relationship between this parent and this child. So as a result, some of the skills that are taught in this phase involve things like praising the child, being reflective, imitating the child, being enthusiastic. These are described by the acronym PRIDE. There's also a phase called the parent-directed interaction, which focuses now on helping the caregiver to use effective non-physical child management skills to enhance the likelihood that the child will respond to requests or commands or instructions, or at least to provide safe and effective consequences to deal with the child's misbehavior. So in other words, you think of this as being focused on developing positive repertoire between them for enhancing the relationship, as well as for helping parents use effective strategies to discourage unwanted behavior. And what's unique about this intervention is that skills are observed through a one-way mirror. It's very detailed. There's usually a bug in the ear for the parent so that the parent can actually hear the clinician providing the coaching instructions, as they occur while this parent is interacting with his or her child. So it's very detailed, very focused, with kind of immediate feedback being given. And what's nice about it is there's homework to follow up on the actual assignments that they practice in the session. And the skills, begin in this laboratory-like, or clinic-like setting where there's a lot of, conversation and discussion and a controlled circumstance, but eventually it moves more towards the home and then unstructured situations. So there's a lot of precision built into this particular intervention. And what's nice about it is that the curriculum, the skills are extremely well laid out, very detailed, and they build upon one another in a very nice way, so that it helps the learner kind of master more material over time that builds upon prior material, and it helps the trainer kind of recognize, well, we've done the basics, now we're going to move on to the next set of skills. And I just wanted to highlight some of the research for this particular approach. There are a couple of studies that have been done with physical abuse. I'm not really talking about all of the wonderful work in this area on PCIT with non-physically abused cases. I only wanted to talk about physical abuse. And there are a couple of studies, and again, what you see is that one of them actually randomized physically abusive families to either PCIT with enhanced community services, getting other additional services, or they sent families to the community to get standard parenting groups. And what they found was that the PCIT group had lower rates of reabuse relative to the standard community group, and it had other benefits, such as, when you observe the parent, the PCIT-trained parents had fewer negative behaviors. They all engaged in more positive behaviors, but they also found that adding services to PCIT in the community didn't necessarily improve the benefit of PCIT. There's another study that looked at the outcomes of a large sample of children who'd been physically mistreated, maltreated, and that study also found that after treatment, those children showed reduced problem behaviors and were more compliant. And then Chaffin has a more recent study which looked at not only the benefit of PCIT versus community services, but whether or not those who were going to be randomized to either of those treatments, if they received an initial orientation where they either received motivational interviewing, a self-motivation component, or just a routine motivation component, what they found was that the effects were the best if two things occurred. One, the family received this motivational interviewing preparation and then received PCIT. So what this says is that you can even enhance the outcome of PCIT if you add to it a motivational interview, a motivational intervention. And as I mentioned, if you look at the work of Sheila Heiberg, you can see there's a lot of extensive research on the value of PCIT with behavior problem children. But that isn't the focus of today. But I just wanted to highlight that it has a really rich history here. Okay, so I want to turn to the next treatment. Again, I'm just trying to give you an overview of the highlights as well as the research in the time that we've got. So AF-CBT is a bit different in that it adds more on the cognitive side. So some of you are familiar with CBT or cognitive behavioral treatment. This is a CBT in that it adds more elements dealing with cognition and emotion. And the focus of AF-CBT is on coercion and conflict, which includes aggression as well as abuse in school-age kids up to the age of 17. It includes 17 topics in different phases. Some of the skills that are taught in AF-CBT relate specifically to an incident of abuse, and some relate to just more general skills. Like problem solving is a general skill. We can use problem solving for anything. You don't have to necessarily tie it to an experience of abuse. Whereas if you're going to have your caregiver apologize for hurting you and put that in a letter that they're eventually going to read, hopefully in a genuine way, that's an abuse-specific skill. That's specifically taught and tailored to the circumstances around an actual abuse incident. So this intervention includes some abuse-specific skills and some general skills. In terms of its format, it meets sometimes alone with a caregiver, sometimes alone with a child, and sometimes together. It has 3 phases. There's an engagement phase, there is a skill-building phase, and there is a family application phase. And what that means is that the engagement phase really tries to understand the family, its strengths, its challenges, understand what happened, learn a little bit about a referral incident or an abuse incident, learn a little bit about the physical and verbal characteristics of the home, how much positive talk goes on, how much negative talk goes on, how much do people use physical force in the house, how much do they use threats of physical force in the house. All of that is part of the engagement phase. And then there's an educational piece within the engagement phase to talk about the impact of being exposed to either harsh verbal comments like criticism or actual physical force. And then there's a skill building phase. And the skills are listed at the bottom of the slide. One, for example, has to do with teaching the child and the parent separately how to regulate, control their strong emotion, whether that's anger or anxiety. Parents who get very explosive very quickly sometimes regret what they do next, and they might engage in hostile, aggressive behavior. And so one of the thoughts is, could you lower the risk of that if you teach these anger self-control strategies? And those usually involve relaxation, some way to kind of quiet the person's physiology so that they're a little less likely to feel very compelled to explode or engage in behavior that they otherwise would worry about, like hurting a child or like saying something they otherwise wouldn't like to say. So somehow getting control over someone's emotional level of tension and being upset is an important component of this model. There's also work done on cognitive restructuring, which relates to the issue I mentioned earlier about having misattributions. A parent who sees their child as negative or the source of all their problems will probably mistreat that child. How do we help parents kind of look a different way, come up with a different view of their kid or their kid's behavior? It isn't an easy thing to do, but again, this is one of the things that is focused on here. And like some of the other approaches, there is a focus on teaching positive parenting, non-physical punishment skills like removing privileges or using time out effectively, teaching social skills to children, an abuse clarification piece where parents who have engaged in some type of abusive experience can kind of take responsibility and apologize and highlight to the child what might be new. And then family communication and problem-solving skills, teaching parents how to talk nicely or at least a little more nicely than what they usually say, and to avoid some of the communication obstacles that often make this difficult for families. So what about the research literature? There are a couple of studies, again, just briefly mentioned. One in which there were 2 conditions in an early study. One was individual CBT, where the child and the parent received many of the CBT CBT skills I just mentioned, but they received them individually versus they received some of the family intervention components like problem solving and communication jointly. And those two conditions were compared to cases that went into the community. The two conditions that received either individual or family therapy showed a number of improvements. Those caregivers were less likely to use physical force, they were less aggressive, their children had fewer behavior problems, and their families, both the children and the parents, reported that they were more likely to feel closer together, so more cohesive, and they were less likely to engage in conflict. A second study we conducted in 2011 was in one agency in another state, and basically what they learned was that the more AF-CBT material that was used in cases that received it, who had been physically abused, the more likely the child was considered to be safer at the end of treatment by the parent as well as by the clinician, and that the child was actually more appropriate and more respectful of other people and had a better prognosis for doing well in the future. We've also conducted a study to train staff in AF-CBT, and this is a study that's just been published. And all I wanted to highlight from it was what we learned was if you provide training to practitioners in routine community agencies and compare them to practitioners from the same agency who don't get the training, you show a significant improvement in the knowledge of CBT and in the use of these AF-CBT methods only in the group that received the training. And we have used some of these methods with children who have been involved in behavior problems, not necessarily who have been physically abused. Again, small research literature. I'm happy to provide references to folks later if you're interested, but just to highlight some of the benefits of this approach. So I want to say a little bit about a related approach called Combined Parent-Child Cognitive Behavioral Therapy, and CPC, CBT. And what makes this approach unique is that it also provides a comprehensive set of intervention routines and procedures, but its focus has been with abuse cases that also have some level of post-traumatic stress disorder. So as a result, you're getting cases that have also met criteria for having at least some PTSD symptomatology. And so they're focusing on those individuals who actually are showing now traumatic reactions in addition to having been physically abused. Another novelty of this intervention is that it includes several sessions in individual work, but it also has a group component. And it's one of the few of these 4 interventions I'm talking about that includes group. It includes a parent and a child who meet together, and then they usually separate, get separate programming, and then they come back together for a check-in in a way at the end of the session. And similar to AF-CBT, it has an engagement phase and a skill-building phase, but it also has a separate family safety planning phase, and then it also does an abuse clarification procedure where parents who are willing, who have engaged in abusive behavior, can write a letter and work out language that can be used with the child in a session to actually take responsibility, apologize, and then mention to the child some of the different rules or routines in the house that will be made so that the child will be safer in the home. And I want to just highlight some of the skills of this intervention. It too incorporates engagement strategies such as motivational interviewing, which is an entire area in and of itself that has a very, very strong evidence base. It does psychoeducation around trauma. You know, parents sometimes don't know very much about, you know, what are the likely effects of being exposed to physical abuse. So they might misunderstand a child's behavior, and perhaps it's helpful to highlight that those types of problems actually are common in children who've been exposed to this experience. They teach positive coping skills as well, so anger management, anxiety management skills to both parents and kids. They teach also this kind of more positive family communication, positive parenting skills. They work on a family safety plan, which also includes something like a cool-down procedure, and this idea of abuse clarification, where again, parents can take ownership and responsibility. So in terms of research, there's a study that Runyon has done in 2009, and it was an initial pilot study, and it really just looked at those cases before and after the group who had been physically abused, and they found reductions in the level of the child's post-traumatic stress disorder, less physical punishment, parents reported less anger after treatment, and they also reported fewer child behavior problems. And then there was a controlled study in 2010 that Runyon did, in which she compared the full intervention program, which means all the individual work, the family work, and the group, versus just the parents getting their own intervention. So no child was included in the comparison condition. And what she learned was that those families who received the full intervention showed more improvement in the child's PTSD symptoms and more improvement in positive parenting. But the parent-only group showed a greater reduction in their use of physical punishment. Okay, so the last intervention I want to mention is MST-CAN, Multi-Systemic Therapy for Child Abuse and Neglect. And this is a little bit different from the other interventions in this way. MST was developed mostly for adolescents who were engaged in pretty serious antisocial behavior or who had substance use problems, and many of those youth were at risk for being sent to juvenile justice if they weren't involved in juvenile justice already. So think of this as an intervention that has traditionally been developed for a more dysfunctional and an older youth population. So as a result, the intervention usually lasts a little bit longer. It's usually developed for 6 to 9 months. It is a very comprehensive treatment in that part of the goal of MST is to identify what the individual needs of a family would be and then to figure out how to get them. And so it could include therapy, it could include drug use treatment, it could include domestic violence work, it could include case management. So linking families or parents to services for their own depression. So it's much more comprehensive. Almost all of it is done in the home, and it's tailored to the needs of the family. So it's less focused on the content and more focused on the process. The process is that they use principles, not so much procedures. They have procedures, but they're driven more by principles that help them figure out, what does the parent need? In what way can we include the parent? And they use a lot of functional analysis, meaning very detailed methods for examining why a behavior is occurring and how to change those conditions that make that behavior happen. And so this is, again, one of the novelties of this intervention. So it's much more broad, it's much more home-based, and it's much more tailored to the individual needs of families. And some of the skills are similar to the ones I've mentioned, such as doing safety plans or helping to understand why is a parent using physical force. What are the characteristics in that environment that make this caregiver likely to use physical force? And how can I change those characteristics so that this parent is less likely to do that? They also teach things like anger management, but they also have treatment for PTSD and substance abuse, as well as family communication training. So you can see it's a pretty diverse array, some similar to the ones I've just mentioned, but this could include actually far more elements and intervention components than I've mentioned so far. So these are the 4 evidence-based approaches that are found in the literature as having been developed for and used effectively with cases that have been referred for child physical abuse. Oh, and I want to just mention one other thing about the MST outcome literature. There actually is a very extensive MST literature going back many, many years. But the one study that I want to highlight by Cynthia Swenson is a study she recently published in 2010. in which she found that this particular intervention with physical abuse cases had a number of advantages at the end of treatment. These were youth, and again, you have to remember these are youth who are usually older and very dysfunctional. These were youth who showed reductions in their internalizing symptoms, their total problems, as well as their post-traumatic stress. So you could see broad effects on a variety of clinical problems. The caregivers who received MST showed greater reductions in their own distress, their own clinical or psychological symptoms. They also reported improvements in social support within the family. They had fewer reductions in appropriate discipline relative to the comparison group. So they're trying to be a little bit more stable and a little bit more reasonable over a period of time. And then, in addition, they have information to suggest that those children exposed to MST were less likely to be re-abused. So there's an evidence base for each of these, and I encourage you to look at them with that in mind, because they have been demonstrated to be reasonably effective. Now, there are other interventions that may not have been used and studied specifically with physical abuse, but they may have been involved with cases who have been physical abuse. For example, many cases involving sexual abuse may have been physically abused at one point. But these are interventions which have a strong evidence base, but they haven't reported separate evidence for physical abuse only. But I would be remiss if I didn't mention them, because they're both good and because they're commonly used. And they may be important in different types of cases. And I just want to mention them briefly. Child-parent psychotherapy is an intervention mostly designed to help younger children who've been exposed to either domestic violence or intimate partner violence. So they've seen aggression and violence in the home. Now, some of those children have been physically abused, but they may not have been. And so this is an intervention mostly to deal with their exposure to usually parents, caregivers engaged in domestic or partner violence. Cognitive behavioral intervention for trauma in schools, CBITS, is a very interesting intervention because it's done in the school. So for those of you who work in schools, this might be also useful to consider, and it too has an evidence base to show that it helps with kids who've been traumatized. The Safe Care program is also one that focuses on very specific behavioral strategies used with caregivers, often in their homes, teaching very specific skills. It has mostly been used lately in cases where neglect is the primary problem, but many of those cases also have occasionally had histories of physical abuse. So I mentioned it here too. And then finally, trauma-focused CBT, AF-CBT, has also been used with a broad range of traumas, has a number of outcome studies, good literature, strong literature in terms of science support, and it too has been used with cases that might have a variety of forms of abuse. But again, none of these has reported a specific study where they actually look at the outcomes in physical abuse per se. So I just want to point them out to you as references. Okay, so for the last part of our presentation, I thought I would leave the research literature, and I know for some of you that couldn't have happened quick enough. And I want to just say a little bit about other material and information that might be relevant, whether you have a family like this, whether this is your family, whether you refer families to treatment, whether you provide treatment, or whether you advocate, or whether you fund treatment. I wanted to point out the National Child Traumatic Stress Network. Some of you may know about this, and I've listed the website, which is www.nctsn.org. And the reason I mention it is because this is a congressionally mandated network that has for 10 years now been developing a response and materials to address the problem of child abuse and neglect, and especially child trauma. And I really encourage you to check their website, where there is a lot of free material that is very, very useful, and it's developed by many of the people whose work I've mentioned here today. And I really want to just give you a flavor for some of it. And these are screenshots taken from the NCTSN's website, and they have a section there dealing with child physical abuse. I realize it might be hard to read exactly what's on this, but I just wanted to give you an idea. So, for example, one of the documents you can draw down, and again, you can use this with families or you can send this to clinicians or put it in a waiting room, is a fact sheet on child physical abuse. Something about the prevalence, how many cases, who are the individuals who engage in this behavior, sort of what are the characteristics of individuals who've been alleged to have committed abuse, what are some of the characteristics to look for in a child that might suggest that a child has been physically abused. And this goes on, it's not as longer than a page. But what's nice about it is it's meant to be written in pretty simple language that can be used and hopefully in kind of a public education format. Meaning if you want to provide someone with some basic information about this particular problem and not written from a particular slant and hopefully not too critical, meaning it's meant to be just an understanding based on what we've learned in the field, this is a reasonable pamphlet or document to provide them with. Another example is there's a question and answer section that I did, and I just have a sample of it here. It's a little bit old by now, and it's just meant to answer common questions, that parents sometimes have had or that professionals have had about, how widespread a problem and, what are some of the effects and are there interventions and what are the interventions and, what would you do if you've identified a child? So again, this is really meant to be the kind of information either you as providers could use or you could provide to your families or, frankly, make this available to your stakeholders, people who help refer cases to you or other individuals in the community organizations, for example, who might benefit by having more of this information. And again, it can be drawn down and downloaded for free from the NCTSN website. And I will say a lot of this material gets updated, so other documents that you might find on this website will be reviewed and modified. Now, I'll give you two examples. There is a work group that actually is through the NCTSN, and it's a work group on child physical abuse. And I'd actually mentioned that if anybody was interested, there's a way to get involved through the NCTSN, and I'd encourage it. And this is one of the products of that work group, which is something around physical punishment. And again, I can appreciate this is an emotional issue for many and an issue around which there is a lot of debate, both in the science literature and even in society. So there really isn't a right answer or a wrong answer, but the work group has tried anyway to take what it has learned about the use of physical punishment and to put that in a document that might guide parents. Now, again, every parent and every professional has a different opinion about the role of physical force. And I think this is just an attempt to provide some information so that parents know more about, let's say, what the effects of physical punishment might be, or to know a little bit more about in what ways physical punishment has been encouraged. There are certain ways that certain interventions that encourage the use of physical force have taught parents to use physical force in order to minimize damage to the child or injury to a child. So I think the whole point is to provide a mix of both science understanding and practical tips around the use of physical punishment and guidelines if a parent is concerned about their use of physical discipline. And I have to say, in my experience, there are a number of parents and caregivers who may use physical force, but who are wondering about it. It may be that someone has actually tried this or they actually are relying more and more on physical force or physical discipline, but they're equally uncomfortable. They're still a little bit distressed by the impact, or sometimes there's frustration. I don't know what to do differently, so I'm doing this in the hope that this is going to make an impact on my child. And so as a result, information like this to that parent might help that parent decide, well, do I really want to persist in this? Maybe they do. but they've learned a little bit more about how to do this appropriately or in a more effective way. On the other hand, it may allow a parent to make a decision that says, you know, based on what I'm learning or based on what this recommends, maybe it's not the best idea I do this. So I don't think it's trying to simply say don't do this. I think it's trying to say, here's what one ought to know as a caregiver if you're thinking about or actually using physical discipline. So I think for that reason, it has merit. And again, I encourage you just to take a look at it to see if it will serve your purpose. Now, we're not all about just simply getting rid of physical discipline or changing physical discipline or doing it well. I mean, physical discipline is only one aspect of raising a child, correct? And socializing a child and interacting with a child. And so one of the nice products of the NCTSN's work group is this document on raising well-behaved kids and what parents ought to know. And some of this is on discipline, but others are not on discipline. It's more on, you know, speaking to your kids and being involved with your kids and providing your child with stimulating, appropriate, healthy experiences, things along those lines. And it's not really meant to be specific tips on everything known about how to raise a well-behaved child, but just some general guidelines, especially for those parents who say, well, I might want to try a little bit differently. I just don't know yet what to do. Maybe this is going to help them move in a certain direction by giving them a couple of common sense and practical suggestions. Now, I want to mention one other document or one other material from the NCTSN. This is a video that our group and the group at Allegheny General Hospital developed for informing individuals about family-focused interventions that are effective for child physical abuse. And this is actually the cover of this DVD that is actually available on the NCTSN website. The video is actually there. You can download it, you can watch it, you can save it to your laptop and put it on a DVD and give it to parents if you wish. Again, it's meant to just provide information about child physical abuse on a couple of fronts. One, it's meant to say a little bit about the prevalence and the degree to which child physical abuse occurs in the United States. So there's a little information about what it means, a little bit about its definition, a little bit about the prevalence rates, a little bit about its impact on children. So what have we learned about some of the consequences of being physically abused? So it has some of that information as well. It has information about the risks for physical abuse. So there's some information from various experts around some of the common risk factors, the contributors to physical abuse. It describes some of the interventions I just mentioned to you today, and it gives a little information about the characteristics of interventions that I mentioned as well, that parents should look for if they want to find an intervention that works or that has an evidence base. And then there's a case in this video of a family that actually was seen in one of these treatments. And you see the family over time talk a little bit about their experiences in treatment. You hear the mom especially talk about her history and what her history was like growing up, what her history was like when her children were young, and a little bit more about some of her worries and fears and concerns as she was engaging in pretty harsh physical and verbal abuse. And then you see a little bit about their course of treatment. So there's information from the therapist is interviewed, and she provides some suggestions and comments about the case. And then you see the family at the end, and you learn a little bit about their history and how they progressed. And it's just meant to give one example to probably families who might be wondering about treatment. Gee, can I benefit from this? Do families generally benefit? In what way do they benefit? So some of the outcomes that might occur in treatment for physical abuse are highlighted in this video. And so again, what's perhaps helpful is that if you give this to a family or you see it with a family, while it may highlight some of the stark, serious realities of physical abuse, it has a hopeful ending, and it also talks about how even difficult families can overcome their difficulties, which again is one of the messages, I think, for treatment or intervention. So anyway, those are some of the materials that are available on the NCTSN website, and I encourage you to really look at the site. So the last few minutes, I just wanted to close with a bit of a summary and highlight a couple of things. One is, we've talked about these different interventions, and they have somewhat of a different set of goals. Some are similar, some are different for treatment. And I wanted to mention these because those of you providing services might think about these different goals as being relevant to different cases that you might have. So for caregivers, one of the goals, of course, is to get a caregiver involved in a behavior change process, a willingness to learn something new and try something new. That's probably one of the main goals and one of the early goals. A second, of course, is that once you have a commitment to working on something and changing, you've got skills training in different parenting practices. How do you shift from using power and control and punitiveness and threat to perhaps more psychologically relevant and positive-based strategies? Now, and there's nothing wrong, of course, with having other strategies like punishment strategies so long as they're effective and they're safe. So changing parenting practices is a very significant goal in almost all of these treatments, even if they sometimes go about changing them in different ways. A third goal, which I guess is true for most of these interventions, is that there's an attempt to change the person a little bit intrapersonally from within, meaning getting control over one's either emotional upset or getting control over one's thoughts and views, and teaching self-control methods so that someone can regulate their behavior better, stay in control. And then the fourth is that there's some attempt to help parents understand and overcome and take responsibility for any type of serious physically abusive experience or incident that has occurred, to help a child realize that things can be better and that this parent is going to make the home environment more appropriate. For children, we've tried to focus on a couple of goals. One is increasing their positive behavior and reducing their negative behavior. Okay, so if a child has been aggressive, a child has been non-compliant, we're trying to change those behaviors, but we're also trying to help that child learn more social skills. We want to teach kids, especially children who have trauma-related emotional symptoms like high anxiety, post-traumatic stress, or high anger, how to also stay in control and regulate themselves. We try to teach them how to process, understand, and have an appropriate attribution around a traumatic event that has happened to them, as well as promote their safety. And then the final goal, and again, sometimes focused upon a little bit more in some treatments than others, is how do you reduce the risk of aggression or physical abuse in the future by changing characteristics of the home. As an example, if physical abuse almost always occurs after people get into arguments that escalate into physical force, throwing things, and then hitting somebody, the idea is to figure out how do you change what they say at the very beginning of that process. All the emotional stuff, all the verbal information, material that's mentioned. If that's negative and hostile, how can we change that so that the likelihood of them actually getting escalated into abusive behavior is lower? So just a little comment on this literature, and then I'm done. One is some limitations, and there are many in this literature. One is the samples sometimes differ a lot. So some of the samples in this literature include actual physical abuse cases who've been referred by child welfare. Other cases are self-referrals who are worried about hurting their kids, but they're not in the system yet. They're not being referred by child welfare. Now, those might be similar, but they also might be different in a lot of ways. So we've included in some of our studies a mix of both. And I would just say that's one of the issues we have to address. We have to learn more about the actual physical abuse cases and see if their outcomes are different than those who perhaps are at risk. Sometimes the samples are small. And again, these are the research issues that we all have to address if we're going to improve the science base. Some studies focus more on the clinical outcome, the well-being of the child. Others focus a little bit more on safety, like is there re-abuse? They're both relevant, aren't they? We want to know that kids are safe. Yes, we don't want them to be re-abused, but we also want them to be clinically appropriate. We don't want people to be sad and unhappy and miserable. So both of those outcomes are important. We want them to be exposed to re-abuse less, and we want them to thrive and have better mental health and have better adjustment as well. We don't know a lot about who responds to treatment. In other areas we do. We don't know that much about that in this area, and this is a gap I think, I hope anyway, that the field will address. We don't have a lot of independent replication. Many of these studies are done by the developers. It would be wonderful to see more research being conducted outside of the lab in which a treatment was developed to show that they too could use it in the same way. And the models vary. You know, they vary in the complexity, in the number of skills they teach. Some teach a small number, some teach a broad number, like all the cognitive behavioral treatment skills. Some of those are very diverse and complex, whereas other treatments might only teach primarily parenting skill. We have to recognize that the intervention models vary in complexity. They use different methods. I mentioned the PCIT relies on coaching through one-way mirror. The other interventions do not. They're much more of a use role play and information, give feedback with a parent or a child or both together, but there really isn't that same process through a one-way mirror. Some, as I mentioned, are primarily behavioral, some are cognitive and behavioral, and then some vary on how much treatment is individualized. I mentioned that MST does a lot of individualization, and there really is no specific intervention components. There are some, but really what they do is they individualize every case. And then finally, research directions. I already mentioned a couple of these, having larger samples, looking at the characteristics of moderators. Moderators meaning, what is it that looks like it affects the outcome in a given intervention? Who responds well in a given intervention? If you're a two-parent or a two-adult family, are you more likely to do well in a certain treatment or not? Be interesting to learn that. We don't know much about the core components. You know, we have lots of skills being taught. We think they make sense, and we think they're necessary. But research might tell us they're not necessary, that some of them are actually less effective than others. Now, that would help us condense our treatment and make them more focused. We don't have very much information on cost effectiveness. What is the cost of treating a case? This is an economic analysis. Again, we haven't really done much of this in the child physical abuse area. And we haven't done as much in terms of dissemination of this material. Now, the NCTSN website is an attempt to do that, but we haven't really figured out how to get all of these materials and services into the hands of people who need them, and then how do we get all the families who need this kind of work to get these services? You know, we have to figure out ways to make it more accessible and easier for them to use and benefit from. And that probably means using some technology. I mean, the internet is an obvious one, but what about cell phones, where now everybody's getting suggestions and comments and information on a broad range of topics on their cell phone. There are many apps now for therapy related constructs. Is it possible that we could do something with technology here? So anyway, this concludes the presentation on this particular topic. I did want to thank the contacts who sent me information about the 4 interventions, and I've listed here their names and their email addresses and their phone numbers so that if anybody is interested, they could contact them either for more information or to talk about training programs or just to learn more about their interventions. And so with that, I'll just say thanks very much. I appreciate your being here, and I hope this was a useful hour. So thanks.